Speaker for today's session. Dr. Archana Areti needs no introduction. She'll be talking on medication errors, again, wrong decisions, and lateralizing errors. And second talk is by Dr. Subramaniam V. I'll introduce him once he comes onto the forum, please. So may I request Dr. Archana to proceed, please?
Sure, sir. Thank you so much, and welcome everyone to the 8th Air Rounds, where we discuss all incident reports in anesthesia and patient safety regarding that. So it's my privilege to present here today, and thank you, Sunil sir, for that introduction. So let me just start. So today actually the presentation was supposed to be made by Dr. Dipinder Kaur, who is an associate professor from the Department of Anesthesiology at High Tech Medical College and Hospital in Bhubaneswar. I hope my slides are visible. And
Yeah.
so I thank Dr. Dupinder for preparing for the presentation. Unfortunately, due to a family emergency, she could not be here today. So on her behalf, I will be presenting. So the topic for the first discussion today is about wrong side, wrong outcome, preventing laterality errors in regional anesthesia. Okay. So no matter how the basic point of this discussion here is, no matter how technically perfect or sound your block was, once performed on the wrong side, it's still considered as a failure. So this particular incident was reported, and in the most latest web letter of the incident reporting of July 2026 edition. So basically, what was the clinical scenario is that where everything went right except for the side. So the case was a 68-year-old gentleman posted for an elective left-sided total knee arthroplasty. The went through the motions, the checklist was confirmed, the consent was signed, the ultrasound was done, and a femoral nerve block was performed with an excellent needle visualization, circumferential spread, and no complications. However, when entering into the OT and when patient was undergoing prep, they noticed that the patient noted that the right side was numb. So he asked, as a feedback, how come, are you still operating on my left side? So unfortunately, even though the block was technically perfect, the wrong side performance made the entire this as it's basically a never should have occurred kind of an event. Okay, so despite the technically flawless block, the consequences were quite grave. The surgery was obviously delayed. There is again, you have to perform another procedure on the other side. And then, of course, you have to do a root cause analysis and of course the explanation to the patient and of course the team, and not to mention our own conscience when it comes to things. So how do we proceed from here? So why does this actually matter? I think this is quite generalized to everyone here. It's primum non nocere. The rarity of it does not diminish its consequence. Fortunately, we are all very vigilant and when we do it. So it really does happen very occasionally. So it can cause direct patient harm. It causes an institutional impact. And obviously, there is the second victim, that is us. So when this happens, what is actually a laterality error? Basically, it encompasses a spectrum of preventable procedural errors, not simply left versus right confusion. So it could be a wrong side, it could be a wrong site, it could be a wrong procedure in itself, or it could even be the wrong patient, which hopefully we just generally, don't get to face most of the time. So, yes. So, all of these are classified as never events. They are serious, they're preventable, clearly identifiable, and of course, a proper system in place should make them amenable to prevention totally. So, even you're technically perfect, if you're on the wrong side, you're a fail. So, then what's the epidemiology behind this, the burden of these kind of errors? Basically, it is an underestimated incidence simply because a very fraction of them are being, reported. Fortunately, now with the Docked app in place, and I hope that all of our listeners and all of the people in tune to us today are using the Docked app now more vigorously to report these errors so that the exact incidents can actually be, reported. Because what this can actually do is help us to propagate stronger systems to be kept in place in order to avoid such never miss or near miss events. So while the actual occurrence of it happens, there are several incidences, quite more a number of incidences where there will be a several kind of a near miss situation happening. I mean, I cannot mention how many times in my practice also that I would have got them into a prone position for a procedure and then the side gets switched. So but then you realize it in the end because we have checklists in place. It goes through in our mind key all the time, is this the right side, is this the right side? So but there are some vulnerable areas, vulnerable zones where we should really be a little bit more vigilant, especially in high risk settings like high volume trauma cases are more, and there's a time pressure to get everything out and done, especially when you're doing regional anesthesia, when you're not might having a separate procedure room and you don't have the intense monitoring of the OT. In those sort of times also you can have a issue on a vulnerable, a weak spot, let's say. So also all where you have trainee involvements, not just at the postgraduate level, but also when you're catering to allied health sciences technician students, and these sort of involvements are there. And also the early morning lists where there you have the number on the same kind of cases, like you have 4 cases and 3 right and 1 left, and it comes in between, and then you get, there's a little confusion happening in between. So we should be very careful, whichever it is, and always not try to rush it. Even with the time pressure, we should keep calm and then try to push through and try to cover all the aspects of the system and try to avoid this error in the first place. So when it comes to this, whether it's a human error all the time or it's a system failure also. So it's both. As human beings, we do tend to error, but what makes us is that we learn from our experiences and then apply it to the next time and try to avoid similar concepts in the future. So basically, it's not just a human error, but we should really be as vigilant enough to put in systems in place to create a system that whoever falls into that, whatever kind of piece falls into that system, it will just follow and it will cover up all of these holes, so as to speak of. So the systems approach, or the Swiss cheese model, which was propagated by James Reason, who was a British psychologist, he said human error is inevitable. Okay, but by creating systems in place, you can identify the weak points, wherein only when it's not just 1 or 2 factors, but if all the factors fail is when the complication or the event happens. So these sort of things, when you put in a system and you put in the checklist and you get them followed, hopefully they can reduce the human limitations, and especially relevant to regional anesthesia, where there can be fatigue, there can be the cognitive overload, a production pressure, that pressure to succeed and make sure your block is perfect. So you, especially when you're starting out, you're focusing more on the technique rather than on the, small, simple things that can be overlooked. So that being said, so what are these bias that occur in the human factors, okay, that are preventable in the perioperative setting? Basically, there's a confirmation bias where you assume the right side is correct because you did a similar kind of cases before. The expectation bias, reading right on, so there are different places where things get noted down, like the theater board, then there's a separate printed list, and then there's a separate thing, case sheet. So 3 different areas have to be confirmed. How many other areas are there? And then you still have to, that can also get missed. Then you have the automation bias, where you trust the electronic operating list. This happens quite frequently, especially since the operating persons or the persons responsible are not probably the ones making the list. It's probably an intern or a secretary. So in that case also, this can get missed. Then you have the tax fixation problem, wherein advancing you're focused so much on doing the block that you would have missed, the aspect of actually finalizing the finer points before actually attempting the block. And then, of course, the production pressure, wherein you want to avoid delaying the list. So you just assume it's right, and then you just keep going and then forget to cross check. So these are all aspects that can happen. And there's several little systems that are there and things that need to align. This is precisely what is the Swiss cheese model, which is Swiss cheese is basically the type of cheese that has holes in it. And even though the holes are of different sizes or in different places, when they can align, then you just have that patient slipping through those holes and you end up in the complication. So an example how these holes can align when you're doing regional anesthesia is when the patient is sedated before verification, so you can't even ask the patient. If the site mark is hidden by positioning, or sometimes they have bandage rolls or something sterile markings wrapped around, so you might miss it. An operating list, might have a discrepancy with the consent form, which should be checked again by the same people. So then a block performed before, talking to the surgeon review. And then when you don't have a specific, all of us have surgical checklists for the surgery, but when you don't have the same thing, a similar thing for a block or a regional anesthesia, especially when done in the separate procedure room, is also another time how this can happen. So basically, these errors are not additive, they are multiplicative, and closing even one hole can prevent the event entirely. So even though all holes need to align in order to have the complication happen, even if you close one of these holes or even catch it at any one point in time, essentially a whole, this is a near miss, the whole event can be avoided altogether. So beyond this, there is again the systems engineering initiative for patient safety, wherein it asks not why did we fail, but ask which component of the work system increased the probability error. So the key insight is you look at each of the aspects, and then you look at it as a system as a whole, and then look at see how each one of these can be, put into quality improvement rather than placing the blame on any one individual. So key insights for the domain here is for our specific cases, the tools and technology, the ultrasound does improve technical accuracy, but obviously it does not confirm the site. The environment, the noisy, crowded block rooms increase inattentional blindness and distraction. The organization, you should probably put in a checklist in a block room so that, and that every single person performing the block is actually going through the checklist and going through the motions of preventing such errors. So if we go have through a root cause analysis, systematically examine what actually happened, why it happened, and how the recurrence can be prevented, there are several published reports that reveal consistent predictable patterns. One is basically every wrong side block, it should be treated as a system failure until proven otherwise. So it's not just one factor, it's multiple factors. So it could be inadequate identification, incorrect schedule posting, poor site marking, sedation, verification, communication failure between persons, doing the procedures, and also the time pressure. So these are all things that we can, try to checklist and try to recover from. So the universal protocol and WHO checklist, we all know that when it comes to surgery, the check-in, check-out, time-out, time-in and time-out, the different terminologies used around the world. However, the basic concept is the same. Stop before you perform anything. Introduce all of the people during that are involved with the treatment, management, the surgery, and then make sure that every part is thing. So in our hospital, unless all of these partners doesn't even receive the patient in the OT, and then so on and so forth, the checks are there wherein the staff or whoever is carrying out these checklists are empowered to do so. They are empowered to stop the case from proceeding any further so that these such errors can be avoided. So possibly a similar situation should possibly, we should instill it for our regional anesthesia techniques also, especially when you're doing it outside the operation theater setting in a separate block room or henceforth. and always try to perform a stop before you block. So this is the publication by the RAUK group in the UK, where you prep, stop, and block the patient. We also have a recommendation from our own academy, that is AORA India, wherein the protocol and guidelines have come up with a first confirm, then perform, with this colorful checklist that tells what is a definite no-no and what is, you can, how to get from red to green. And you have just a basic checklist where you can just click, and this is a print ready form. It can be instilled into any of the case sheets with your own logos. And then try to make sure that these all are done before proceeding with your blocks. So utilization of technology is obviously a great boon for us. And, especially in regional anesthesia, ultrasound has pushed us leaps and bounds, not just for regional, but in terms of focus and all other points of intervention as well. And basically, but just because it's such a great tool, it's not a tool used for verification. So entirely, you should follow the checklists and really be careful before you embark on the blocks. Okay. Don't fixate yourself onto a simple task, but make sure that you clear the previous tasks before getting to the actual block itself. So site marking and patient engagement, a very simple way to maybe you can do it is, one thing, yes, you hope that the surgeon has already marked the site before the patient comes to the OT itself. If not, we ourselves also can look, confirm, and just talk to the patient and just have a conversation with them, because more likely than not, the patient is not going to be wrong about which side they're going to be having, they have the issue on, and which side they need the surgery. So that you try to confirm it with them itself, and it's also an engaging thing. It puts them at ease, and at the same time you're communicating with the patient and you're also confirming your site for the procedure, right? So building high reliability. So this is based on your own systems, your own hospitals that you are operating in, or whatever the environment that you're placed in. You review the consent imaging before arrival of the patient, verify the operating list, prepare the all the equipment according to the your ergonomics. Before, if you are planning to sedate, before the sedation, make sure that you converse with your patient, make sure you converse with them and you confirm what is the site and where it needs to be performed, and make sure that the marking is visible. Before doing the block, stop, do a checkout, a timeout, make sure everything is confirmed, and confirm it not just on your own, but with the staff or the technician assisting you for the procedure. And once that's done, after the block, document it properly and give the right dose, right technique, and right, drug. So if you do, however, follow in the same way and you do have an issue, make sure that that incident is reported, do a root cause analysis of what could have been done better and how to improve the system. So when prevention fails, how to manage it now? Now that it's done, you at least realization is the first thing. Stop the procedure, understand that it can happen and it's not done intentionally. And what you do, you have to inform the team, you have to assess the patient, and of course you have the duty of candor, wherein the patient has the right to know that when an error occurs, the early honest disclosure of covering what happened, the consequence, and prevention has been shown to improve the patient trust and reduce the medical legal conflict. So we shouldn't just keep it hush hush, be for fear of legal implications. However, the most important way to deal with this is head on and being direct and upfront about it. And then of course, you have to report and do a root cause analysis and see how this could be prevented in the future. Also, supporting the second victim. The involved clinician must not be ignored. They need just as much as support because they are probably and more so traumatized than anything else. So this is the second victim phenomenon that has been discussed in previous topics as well. So there will be the guilt, the shame, the anxiety, and then of course the reduced confidence, which is predictable and treatable. So institutions and departments individually also, they should be provided this structured peer support. And I think with these air rounds, we do just that, wherein we all get together and we share our experiences and anecdotal experiences, especially for the junior consultants and the postgraduates attending. This is a very good platform wherein this also occurs, that you're not alone and you're supported in this as well. So then from the individual, the vigilance has to go to system reliability of this. There is no doubt. Whichever the kind of setup you're working in, it is very possible, even if you're just, there are definitely at least 4 people in this team, the surgeon, staff, and the technicians. So the 5 principles of high reliability is don't be preoccupied with the failure. Pay attention to the near misses as well, and treat every single near miss as a learning opportunity for the future, for your next case and the cases after that. Reluctance to simplify, avoid attributing errors solely to carelessness, because some of the time it's not just one person or one person's carelessness where it has happened. Be sensitive to the operations, respect the workflow processes, and maintain and empower the frontline workflow realities. Understand the logistics that go through it, and then how we can empower them to those of them working on the front line to put in the checks when they are necessary. We should have that commitment to resilience, to recover safely after interruptions and unexpected events, and also deference to expertise. We should never, ever, however far we think we have come, there is always another step to go and always another lesson to learn. So the most knowledgeable, not the most senior, guide safety decisions. So don't be hesitant to ask for help. There is nothing wrong with it. It's just to make a patient care better, right? So safety metrics to monitor. Always look, especially when it comes to regional anesthesia, how many near misses you might have had. Encourage your team also to report it, stating that, giving them that peer support, and that is when your systems can be strengthened. Institute the checklists, and also not just to your own doctors, but also to the paramedical and assisting staff itself. So future directions, can technology eliminate laterality errors? Information systems, everyone is going to barcode and, online systems. Yes, scanning the patient's wristband before block placement can confirm it, but I don't know how many of us have those kind of technologies yet. However, maybe this can be something that to be considered for future hospital systems. You can have electronic consent verification, where there's a real-time comparison of consent, operating list, and ER. So everything, if it's online, possibly this is a very good possible way to where everything is aligned, and the system itself will alert you ki you've mentioned it as left in the notes, the list it is right. So maybe that itself can have a correction. You have smart ultrasound systems maybe integrated that can confirm the site inside when you input the diagnosis into the patient information chart, and also an AI decision support where they can detect scheduling constant inconsistencies, maybe have voice assisted timeouts, and automated documentation workflow prompts. So this is probably where the technology can also help us eliminate some amount of or reduce some amount of these communication failures, some complacencies, and especially in systems where there's poor safety culture. However, the human factors is central, and we still need humans to run the technology as well. So it's not just that the technology is present, but how well we use it and how effectively we use it. So the practical recommendations for a roadmap to zero wrong side blocks would be standardized flow, implement specific, checklists, or stop before you confirm to perform techniques before you get into the actual regional anesthesia procedures. Standardize the setting and empower the frontline or the people who are receiving the case. Empower them, stop, and prevent us from moving forward and proceeding with the techniques. Establish a sterile cockpit wherein when you're doing the procedure, try to reduce the interruptions during the block, verify the needle insertions, and have that closed loop communication with each other. Foster a psychological safety where every team member, regardless of seniority, must feel empowered to speak up when uncertainty exists. There should be no hesitation that, oh, and no assumption that thinking, oh, they're the senior, they know everything. No, a miss can happen in any from a beginner all the way to the very experienced. So, and the very most important lesson is learn from your near miss or anyone else's that you've witnessed, and deserve every single one has to be investigated and noted, and then try to report it so that make the reporting culture also a safe and inviting culture wherein all of us are working together to prevent the harm. So the block safety checklists, I mean, I've shown you already the AORA India one. So you can just follow these simple to make checklists. And there's a dearth of information present online as well. And you should not go ahead with the procedure unless all the points have been ticked. So wrong side route outcome, to conclude and summarize, basically, it's a never event. It should never happen. However, if it does, try to find out what's the event which has contributed to it, and try to close the holes. Don't always blame human complacency in this. Ultrasound is not the definitive tool at the current time being. Okay, so you still need a dedicated timeout for this, and something like an RA UK's prep stop block, or even Aura India's uh, confirm before you perform checklist. So the safest region anesthesiologist is not the one with the steadiest hand, but the one who pauses before every needle. So I will end with this and open the floor for discussion. Sunil sir, have you had
Yeah,
any?
thank you. Thank you, Archana, for the excellent disposition and preparing this talk at a very short notice. Fantastic disposition. Just I do remember three cases, two from the literature and one from one of my friend in another hospital. So I'll quote the literature case. One of the case that I read long back. This was reported from Shanghai, China, wherein a patient was wheeled in for a tonsillectomy procedure. And when the anesthesiologist did a laryngoscopy, he called the ENT and said, hey, this tonsils look very small. They look almost atrophied. Yeah, they're small tonsils, but patient is having recurrent laryngitis and pharyngitis. I think better we remove it, and intubated, and they removed the tonsil. Uh, and meanwhile, they realized that a similar age and weight group patient was opened up, chest was opened up for a VSD in other theaters. So basically, this patient needed VSD. Another patient who needed VSD repair, open heart was uh, uh, taken up for tonsillectomy, vice versa. So the thing is a very serious error. Nevertheless, yeah, the hospital had to settle outside the court. Second case I just read about few weeks back. I think a patient went for some urology procedure and ended up with a cardiopulmonary bypass, and patient succumbed. This happened sometime somewhere in North India, just about a month back. So, as you rightly said, when the volumes are high, of course, these are all wrong patients and wrong never events. But lateralization errors in regional anesthesia, we had one case in the hospital which I know wrong side block was given, but apparently patient was apologized. The mistake was noted. Family was counseled, and they took it nicely because it was just a superficial block. But nevertheless, sometimes suppose if you have end up in something, some complication, then you had it. So these are never events, should never happen. I think we can have everybody else joining in and share their experience, or if at all they want to contribute any of their wisdom.
Manokant sir, do you have anything to add?
Hello. Yeah. Uh, Never even so can't recollect at this moment, but yeah, I'll chip in if I can. So yeah, I'm sure something must have happened. Yeah, I'll chip in once I can hear.
So
Yeah.
what we generally do in our hospital, again volumes are very high. So quite often we are asked to give the block in the block room. We have a area wherein before the OT, I would say in the transit area, sterile area. So we
Yeah.
ask the surgeon to do the tick mark, the Nike mark, on the site on which the patient is undergoing surgery. It could be a nephrectomy, it could be arthroplasty, or it could be simple arthroscopy. But it is very, very important to involve the surgeon and they physically put the tick mark, and then again you reconfirm with the patient the same thing, and then you proceed. There is no point in doing the block with the return, because sometimes what happens is my mother was a victim. Actually, I would say that my mother who underwent cataract, she was having cataract in both the eyes at a very premier institute. It was L.U. Prasad, long back. And one eye was to be operated 1 year later, and eye was to be operated the very next day. And they operated on the eye which was scheduled for 1 year later. She was psychologically very upset. I spoke to surgeon. Yes, sorry, गलती हो गई, लेकिन कैसा भी होना ही था ना कैटरेक्ट दूसरे आंख में भी. Well, that was to happen 1 year later. But see, we being in the medical fraternity and the sheer volumes at LU Prasad, these things can happen. So we have to be very, very cautious where we don't fall prey to these never events. So involve the surgeon before you give the block. They have to tick the site on which the patient needs surgery and make sure that you give the block on that side. And we have this anesthesia patient safety huddle, like Evra huddle. We have created our own huddle. So before, like, you have this sign in, time out, and sign out before you do the procedure, anesthetic procedure also. That's one of the preventive step of avoiding these serious, I would say, errors. Yeah,
So
Managan.
with Neuraxel, since I do a lot of Neuraxel, so it's the wrong drug. So once I was just next to my other colleague, so they gave local anesthetic. So we take local and spinal both in the same 5 cc syringe. So they took 5 cc of local anesthetic to numb the skin. So they gave 3 cc and left 2 cc. That was so lignocaine. And then they drew bupivacaine another 5 cc. But when they give after getting spinal, they just took the local anesthetic lignocaine and gave spinal. So this was a hysteroscopy patient. So with that low dose of lignocaine, we could just do the procedure. But so that was one mistake that happened under my watch. Then epidural catheter instead of diclofenac has been given to epidural into the epidural catheter. Then
That was
once
wrong injection, medication error.
yeah, so
Yeah.
wrong injection events have happened. Yeah.
Mm. So lateralization of wrong side block, medication errors, wrong injections, wrong drugs, all these things are we have to. These are all never events. Should never happen, and you need to build up your own safety systems at each level. And as I think Archana has been every alternate way, a slide she has been saying, stop before you block, stop before you stick the needle onto the patient, so that you don't get a task fixed, or you don't get fixation errors, because there are a lot of human factors that are responsible, that we need to overcome, especially overloaded system or fatigued post duty person doing the blocks. So you need to have your system checks and make sure that the nurse, the technicians, and the surgeon, they're all aligned. Involve them, and it's a team. At the end of the day, it's a teamwork, and we cannot work in silos. We cannot work in isolation, because many a times I've seen junior he has an anxiety of performing the block little leisurely, and they start doing the procedure alone without any help, or with just one technician. So that should never be done unless the site is specified and marked. Yeah. So I think if there are no more questions, can we proceed with the second uh,
Yes, sir. Dr. Subramanian.
discussion?
Yes, sir.
Yeah,
Yeah,
she
Dr.
Before
Subramaniam,
that,
thank you
I
very
would
much
like to.
for
Hello, sir.
coming for the 8th AIR round. She is a consultant anesthesiologist, AORA fellow from RELA Institute of Science, Medical Science from Chennai. Over to you, Dr. Subramaniam.
Sir, can you make him a share?
Before I
Yeah, he is the co-host.
yes,
Okay.
sir, I think I just connected through my mobile, so I think I'm not able to share.
Hello.
Yeah.
He's
Sir,
not
can you?
co-host.
1 second. Which is this? You are Subramaniam.
Yes. Yes,
There are
sir.
two
Dr.
Subramaniam.
Subramaniam.
One is
I've made both the Subramaniam host.
Okay, sir. I'll just share.
Are you able to do it, Dr. Subramaniam?
Yes, sir. Yes, sir. I'm just finding my document. Oh,
Or you can share it to Archana, then we can scroll.
okay. I'll share it to Archana, ma'am.
I think you are the co-host, Subramaniam.
Okay, sir. No, I'm not able to open my document here. I don't know
just
why.
no problem.
I just
He's on phone. Yeah, so he's not able.
It's a PDF document, huh? No. Okay, just 1 minute, sir. We'll get it.
yeah, just
No
a
issues.
minute.
We can continue the discussion. Lateralization of blocks in regional anesthesia, lateralization errors. Anybody has any experience? Viral Parekh? Rinku? Any
Yes, sir.
experience? Yeah.
Sir, actually,
So,
I
sir,
have
actually,
something to share
No,
Yeah.
please.
about that. This happened like a couple of years back in one of my institutes I worked. So there, the patient was about to get shifted inside OT. So we usually give analgesic block to make the patient comfortable before spinal. So in the holding area, the patient was supposed to be operated on the right side, right femur, but the machine was kept on right side. So the person who just came to give the block assumed that the machine is on the
Ergonomy.
right side. So
Ergonomy.
so he came and stood on the left side. He was about to give the block. Then like someone stopped, and the Thomas splint was on the right side. So then we had to interchange the machine, and the person had to come to the other side. That was not noticed in that moment, because the surgeon was in a hurry to shift the patient inside, and he just shifted his previous case to the recovery, and he just came to the holding area to give block. So since the machine was kept on the right side, he assumed that okay, this has to be done on the left side, and he was about to give the block. It was like a near miss.
Absolutely. So the message from Subramaniam case is whenever, even if you are in hurry, don't delay the basics, don't delay the steps
Yes,
of patient safety. Never
yes, sir,
bypass the
exactly.
patient safety steps. Yeah.
I'm getting it shared now. Yeah. Are you able to see?
Yeah, we can see.
So for my topic for today's discussion is say it, hear it, check it, closing the loop on the drug errors. So next slide, ma'am. Okay, please. So yeah, so we know medication safety is one of the cornerstones of safe anesthesia practice. Unlike other specialties, we administer multiple drugs in a very short period in a busy and time pressured environment. So even small lapses in communication or teamwork can lead to significant patient harm. So what evidence say is the failure are among the most common, the communication failures are among the most common contributors for medication error in the OT. So these errors rarely result from one person's mistake. It is mainly because of multiple factors like human factor, system weakness, and failure in communication. So today's case is a perfect example of what went wrong exactly. So as we go through the case, though it may look, the immediate issue appears to be the vaporizer, uh, when we analyze it deeply, it gives a very broad patient safety lesson. So we'll go on to the case scenario. Next slide, ma'am. Next slide, ma'am. Yeah. So the case scenario goes like this. During an induction for an electrolytic cholecystectomy, the anesthesiologist began pre-oxygenation and noticed the patient becoming unusually drowsy despite no sedative having been administered. A rapid check of the workstation revealed the sevoflurane vaporizer still set at 4% inadvertently left on after the mission check. So the assistant later admitted seeing the dial at that setting, but assumed an inhalational. He assumed that inhale was intended, did not speak up. So this is the case scenario. So if we sum it up, the next slide, ma'am. Next slide, ma'am. Yeah, so if we sum it up, so he is a young patient, ASA2 for lab chole, planned for IV induction with the GA. Machine check was done, pre-oxygenation was started, no sedative was given, patient became drowsy during pre-oxygenation. So the anesthesiologist immediately rechecked the workstation. So and he found the vaporizer was on at 4%. So after this event, the anesthesia assistant said, I noticed the vaporizer was set at 4%, but I assumed an inhalational induction was planned, so I did not mention it. So that is what he said. So what was the outcome here? The vaporizer was shut off immediately. Patient thankfully remained stable. No adverse outcome. So it is classified as a near miss. But this incident is reviewed by us for patient safety learning. So next slide, ma'am. So what is the key question in this case scenario? What do you think was the primary error? The vaporizer being left on or the failure to communicate after noticing it? So what would everyone think what was wrong in this scenario? So most of us would think the vaporizer was, if we were in that scenario, we would have definitely pointed out that technician that why did you keep the vaporizer on? So that would have been our thought process, but there is a lot of things beyond that. This is a critical incident. So why is this a critical incident? Fortunately, this patient suffered no harm. So we classify this as a near miss, but the potential consequence of this could have been very significant. So the unexpected loss of consciousness, airway compromise, hypotension, aspiration risk, or even delay in surgery. So these near miss events are valuable. They expose weakness in our system before a patient is harmed. So every near miss deserves the same level of investigation as an adverse event. So we should not just carelessly ignore that this was a near miss event, something did not happen. We should learn lesson from that. We should analyze where things have gone wrong, because anytime this event can occur if such things are not corrected properly. So the next slide, ma'am. Root cause analysis. So whenever an incident occurs, our first instinct is often to ask who made the mistake. So that is how we usually react. So who turned this vaporizer on? Okay, so that will be our first instinct. But this patient safety science encourages us to ask a different question. It should be, why did this happen? Instead of who made the mistake, it should be, why did this happen? This is the essence of root cause analysis. So what is RC? As ma'am already mentioned in her presentation, it is a structured systematic approach used to identify the underlying cause of an incident or near miss. So instead of stopping at the obvious error, we dig deeper to understand why the error has actually occurred and what system failures allowed it to happen, so that we can rectify those system failures in future time. So the objectives of RCA are not just to assign blame, but it is there to identify system vulnerabilities and implement corrective actions that will prevent recurrence. So let us go into before that, we would, ma'am, can you please switch, go to the previous slide, ma'am? if you see the previous slide, there is something called as fishbone diagram. So that is the most commonly used tool in root cause analysis. So it categorizes potential contributing factors into areas such as people, communication, equipment, environment, and organizational factors. So we are supposed to ask questions: why did this happen under each cause? Like, is it because of any equipment? Is it because of people around, or is it because of communication, or is it because of any other? Like the six main causes this fishbone diagram tells us. So we should just question in those different six aspects and systematically explore each category, so that we get multiple contributing factors rather than just pointing out a individual. So next, going on to RC of this incident. Ma'am, next slide, please. Yeah. So in this incident, the immediate cause was very simple. So it was the vaporizer remained on after the machine check. Okay. But however, stopping there would be very superficial. So the active failure was that the assistant noticed the abnormal setting, but he did not communicate it. So going deeper, the latent system failure becomes apparent. So there was no standardized verbal confirmation of machine status, no closed loop communication, and assumptions just replaced verification, and probably the assistant did not feel psychologically safe enough to question the anesthesiologist, which is like very common in our setup. And so see, here we see like how multiple safety barriers have failed simultaneously. So that is the Swiss cheese model, which again ma'am said, like where multiple safety barriers which aligned in a straight line and they like simultaneously, leading to a critical incident. Next, moving on to the human factor contributing. Next slide, ma'am. So human factors contributing. So now the assistant demonstrated assumption bias. See, he believed inhalational induction was intended after seeing the dial set at 4. And there was a confirmation bias. He should have confirmed with the anesthesiologist whether the inhalational induction was actually intended. So he did not do that. And hierarchy also plays a major role. Junior staff often hesitate to challenge the senior ones. And apart from that, fatigue, distractions, workload, and many other factors increase the likelihood of these errors. So again, yeah, this is where the Swiss cheese model by James Reason, this is how it works, like where all um, the errors fall together, and that leads to a critical incident. So next, moving on to the communication failure. Next slide, ma'am. Yeah. So communication failure, the central lesson from this case is communication. So we often think communication means just speaking, but practically, in reality, effective communication requires the message is sent, heard, repeated back, confirmed. So that is this closes the communication loop actually. So this scenario could have been like this: the assistant should have told the vaporizer is on. So then the anesthesiologist should have told vaporizer, switch off the vaporizer. So then he should have confirmed vaporizer is switched off. So that closes the communication loop. So this simple exchange hardly takes few seconds, but that closes the communication loop and removes ambiguity. So the key message here is communication is complete only when the message is acknowledged and confirmed. So without acknowledgement and confirmation, the communication loop is not closed. Next slide, ma'am. So the ways to prevent these, what are the prevention strategies? Preventing these incidents require actions at multiple level. Individually, we must avoid assumptions first, and we should perform a structured machine check, and we should always verify before induction. At the team level, briefing, closed loop communication should become the routine, and system level interventions like standardized checklists, color coding, organized drug race, simulation training, and most importantly, fostering a culture every team member feels empowered to speak up, irrespective of their cadre, or irrespective of their position. Every team member should not feel scared or
I
We
think
lost your audio, Subramaniam.
he's got disconnected. Okay, so let me see here.
Hello.
Yes.
Yeah, Subramaniam.
Yes.
Can you hear us, Subramaniam?
Yes, sir. I'm not able to, see any other thing like presentation or any other thing in the
I think
thing.
you need
Okay,
to
let me
log
continue,
in.
sir.
You need to log in again.
Okay.
Yeah. Are you able to see
So
now?
let me continue with the order. No, sir, it's still, I think, loading.
Okay.
Ma'am? Yeah, now it is seen, ma'am. Yeah.
Okay.
So moving on to the audits. So improvement, cannot occur without measurements. So therefore, regular audits are very important. We can audit the compliance with machine checks, adherence to the WHO checklist, frequency of medication errors and near misses, closed loop communication during induction, and incident reporting rates. So, and after introducing an intervention, audit repeated to assess whether the practice has improved. So we are introducing intervention, and after that intervention is introduced, the audit should again be done to see whether that intervention has improved the practice among the consultants. So this completes the audit, and this drives continuous quality improvement. So next, moving on to the next slide, troubleshooting. What we would have done if we had to face such a scenario. So if it was occurring during our induction, what would we do? So first is to recognize that something is going wrong. So unexpected drowsiness without administered sedatives should first trigger a systematic evaluation. So we should check the airway, oxygen delivery, breathing circuits, monitors, vaporizer settings, infusion pumps, and drug syringes. Then correct the problem, stabilize the patient, inform the team, most importantly, inform the team and document the event, and submit an incident report so that the organization can learn from it. Just we usually tend to keep the near miss events. We try to close the near miss events at our level, but that should ideally be reported so that other people and the institution learn from that. So they'll formulate ways to make sure that such incident doesn't happen in the future. So the goal is not only to manage the patient, but also to prevent recurrence. So take home messages to conclude, I would like to remember 5 points. Number one, never assume, always verify. Second, communication is incomplete until it is acknowledged. Third, near miss deserves investigation because they reveal system vulnerabilities. Fourth, patient safety is strengthened through standardization, checklists, and regular audits. Finally, patient safety is everyone's responsibility, regardless of seniority. Sometimes one sentence, doctor, the vaporizer is on, can prevent a catastrophic event. Sam, thank you.
Thank you, Subramanian, for lynching or for nailing the final slide very, very precisely and very crisply. Any questions or anybody wants to add anything? Archana, Manokant, Viral.
Yes, sir. So I think another thing that would close this loop of communication here is the anesthesiologist also giving a clear-cut instruction to whomever is assisting him or her in the procedure that this is my plan. So my induction plan is this. My plan to manage is with this block. That sort of thing that can be verbalized at the start, so that there's also a clarity between the team managing the case that, okay, this was the plan, something has changed, that sort of a thing. So that could also assist not relying just on the person to observe if something has and assume something has changed, but to actually, oh, but we had our plan, but now has it changed? So to ask also, has the plan changed? That sort of a thing, I guess, could be, taken off by us as well, the primary anesthesiologist.
I recall a case when I was a second year postgraduate. I think we had halothane vaporizers then. I don't know anybody of the current genre is using halothane. But this is a young, like 2-year-old child for herniatomy. And my colleague, PG, was doing the case, and suddenly he called me, Sunil, patient is not responding. The patient was surgery got over, child was almost moving the limbs, and he gave reversal, and he wanted to extubate a little deeper. But he called somebody for the extubation, and suddenly, after some time, he called me. And then this was the era where our monitor was hand on pulse and the color of the skin. We didn't have ECG monitors. So when I just put my hand on the pulse, it was very feeble and bradycardia. When I looked at the vaporizer, it was 5% halogen. So instead of switching off the vaporizer, inadvertently he put it 5%. He rotated in the opposite direction. And it was almost another couple of minutes we could have lost the child. But nevertheless, as Subramanian rightly maintained, if you don't look at the vaporizer or any of those things, sometimes during the surgery they change the circle absorber and the leak starts, and then you had it actually. So you make sure that, in fact, I put a rule in my hospital that vaporizers, if it is changed during the surgical procedure, there is a fine levied on the technician, and the anesthesiologist will be. It has to be reported as an incident. No vaporizers should be filled while the procedure is on, so that they make a check and make sure that things go the way it has to go. And so everything that both of you mentioned, communication, planning, discussion, huddle, never compromise those things, because these are the solid foundations for administering safe anesthesia. Rightly said. Anybody else?
So, sir,
Rinko? Yeah, viral.
thank you, sir.
Viral, viral, I would
So,
say.
yes. So, as nicely Dr. Subramaniam also said, so about near miss, definitely all of us must be having one or another scenario. So, I would like to quote one which I was in resident third year and I was posted in the cardiac OT. So, that point of time, the new first year GMS, means first year residents had just joined. And in cardiac OT, the normal routine preparations was going on, and suddenly there was an emergency case and we prepared the drugs. So I asked at that point of time, we were giving glycopyrrolate to the patient before induction. So I asked the new fresher to just give me the ampule of glycopyrrolate, and he didn't check the ampule and just handed it over to me. Luckily, I saw and it was a carboprost ampule. So I was shocked that in a cardiac OT, what is carboprost doing? Luckily, I checked it and the event was averted. So that was one of the things. From that point of time, I've always been checking twice the ampules or any drug, even if I'm personally taking myself. So I think all of us must be having such sort of incidences.
Yeah, everybody will have a story.
Definitely, sir.
Everybody. Yeah.
But for a carboprost to be seen in the cardiac OT, even I was shocked. From that point of time, we made a strict rule that no such uterotonics drugs to be there in the cardiac OT.
They must have done some combined procedures. Is there a section with cardiopulmonary
Might
bypass?
be, so I was also rotating in that OT, so might be, so then it must have been slipped by someone. So. Thank you.
Sir, I've also faced a similar situation, just like
Yeah,
Viral
Ritu,
mentioned. So I asked my junior to put tranexamic acid in the drip because there was only 100 ml of NS remaining. I was like, okay, put it in the drip. I'll just be back. I came back and the patient's BP was shooting up. I was confused, like, why is the BP shooting up now? We are nearing closure and whatever. I somehow just went ahead, checked the ampule, and instead of tranexamic acid, she had put dopamine into the drip. And it was only 100 ml of NS. Thankfully, I saw it hardly, I think 20 ml had gone in, but the BP was shooting up like anything. And then I had to like discard the fluid and take the different measures for that. So, yep, that was also a very terrible experience that we had. And I
Yeah.
think a lot of us have faced similar problems in the OT.
Yeah. So the best thing is develop a habit of discussing this case without any blame culture. Have just culture in the hospital so that you can discuss and learn from our own near misses. Archana has been emphasizing discuss, deliberate, and never miss. Every near miss or never event will teach us significant lessons. And if we don't learn from our own mistakes, we are fools, I would say. So we need to learn from others' mistakes. It is easier to learn from others' mistakes, but from our own mistakes and near misses, it should never happen again in your life. So that should be the learning from every event. If you don't discuss, if you don't deliberate, ठीक है चलेगा कोई बात नहीं हो जाता है that हो जाता है it should never end with that हो जाता है attitude. So you need to take these events very seriously, introspect them. Like see the case which Subramaniam said was if you take it as serious, it can be trivialized. अरे 4% था उसमें क्या हो गया? Instead of you realized, but that can sometimes lead to serious things if you take those things granted. You never know, but it may snowball into a major event. So make sure that these events are reported, documented, and we have a beautiful, wonderful platform created by Abdul and Dr. Murli has been the project lead of this critical incident registry. Please report this incident. In fact, just today morning, of course, I'm going deviating.
You got muted, sir.
Yeah. Yes, sorry. Just today morning, I got a call from a senior consultant in Andhra Pradesh. The Venflon was accidentally cut. While removing the plaster, the nurse was trying to remove the plaster. It was not coming out. She wanted to cut the hair along with the plaster so that it doesn't hurt the patient. And in the process, she cut the the shaft of the Venflon. And it just went in. She couldn't palpate and then called the senior person, and then they couldn't palpate along the tray because the patient had low base. And then he called me. I said, "You just do an ultrasound if it's possible. Otherwise, have an MRI and call a IR team so that they can trace it. And probably it should get blocked at clavipectoral fascia because that is one of the narrow point. Fortunately, on ultrasound, they could find the Venflon in the forearm. So they could extract it, just a mini vascular. The point which I want to say is these things, discussions, deliberations, and in fact they're planning to discharge the patient. I said at least do an ultrasound and then explain all these things and then discharge. So definitely ultrasound, vascular ultrasound has helped to identify the shaft, and then they could release it, remove it. So these things have to be reported, and we can learn from these incidents wisely because I'm sure many things, similar things must have happened. At least in my own hospital, I remember central line, instead of cutting the sutures of the central line, nurse has cut the shaft of the central line and it just gone inside the IJV sitting in the SVCRA junction, fortunately, and we could retrieve it with the IR team, the different story. But unnecessarily, one more procedure had to be done on the patient, and additional expenditure, CM exposure, radiation exposure. So many things have happened. So please be careful. Don't compromise on patient safety. Biggest lessons, because mistakes in anesthesia are dangerous sometimes. They are not benign. Sometimes they are quite malignant.
Agreed, sir.
Yeah.
So Okay, I think if there's nothing else anyone would like to add,
Anybody?
yeah.
I can see Manokant is there, Ramesh, Tanya, Rahul. Anybody wants to add anything? Praveen Kumar from Visakhapatnam. I think if there are no questions, we'll conclude today's session. I thank again Archana and Subramanian for a fantastic disposition. And we'll see you again after 2 weeks with the AIR rounds 9. Thank you very much and good night to each one of you. Thank you, Rinku, for recording this session.
Thank
Thank
you.
you, sir.
Thank you, sir.
Thank
Thank you.
Thank you, sir. Thank you.
Thank you. Thank you, everybody, for joining.
Thank you, sir.
Thank you.